All right. Well, we got through kind of the preparatory stuff, up through anatomy, physiology. Now, the book has another chapter called pathophysiology. Pathophysiology really isn't that much included into the EMR curriculum. So if you started reading it and you started to get a headache, that's probably why. Pathophysiology, so anatomy, again, anatomy, physiology is how the body and the systems work normally. And then pathophysiology is how disease affects those systems. Now we're gonna weave pathophysiology kind of into each pertinent unit. Meaning like airway tonight, we'll talk about pathology of the airway. And in medical emergencies, when we talk about like difficulty breathing, we'll talk about pathology of COPDs and things like that we might see. So you're welcome to read it. You're welcome to bring questions. The more you know, the better. But I just don't want you to get too overwhelmed. Tonight, we'll kind of get into the airway talk, and then I'll kind of move into our first Saturday, next Saturday. Guys, if you haven't bought a gift, got a few more days. Saturday is Valentine's Day. All right, so I always start, any questions from last week? So everyone's got a pretty good grasp on anatomy and physiology. It's a big topic, huge topic. Anything that you walked away last week going, I think I need to talk about this more. We will revisit it pretty much as we go with each unit. Anything right now that's giving you a mental block before we get started? Okay, well, if I hear nothing, don't be afraid to shout it out if it comes. I guess moving into Saturday, kind of my plan is we'll get going 8. It's going to be hands-on practice with everything airway, so we'll probably have some stations set up. And I think I'm going to do the CPR as well. I did order all the CPR material, the actual videos from the American Heart, especially those that have never taken CPR before. I don't know if they're going to be here in time. But I have taught a lot of CPR classes without that material, so we can probably do CPR, AED in a few hours, some hands-on with airway stuff. We will not keep you till 4, I can promise you. I'm thinking kind of noon, 1 o'clock-ish, we should be getting cut out for it. Now I said it, I got a little too. Okay. Airway management. This is what we teach you tonight is the foundational principles of what every level EMS provider has to do. So what we're talking about for airway management today is the same thing we talk about for paramedics, and it's the same thing they talked about even ER physicians in airway. ER physicians, airway is airway. It's one of the more important skill sets that we will have to learn. If you don't have an intact airway, the person will die. So we need to have that pathway for oxygen to get into our body. I kind of glanced over the topic a little bit in physiology, but I just wanted to dive a little bit more into why the airway is important and how that oxygen that we're breathing right now actually gets to our body. So we know we got to have the pathway, the upper airway, transition into lower airway, down into the functional alveoli where the gas exchange takes place. Did we talk about a word called diffusion? Okay, so how does that oxygen just magically get from the lung tissue into the blood vessels? And the process is really diffusion. So probably not appropriate, but this is the way everyone can understand it. So if I was standing here and I passed gas, who's going to get it first? And then you guys, and then you, right, so on and so forth. So that's diffusion in action. So diffusion is essentially molecules want to equal out within a given space. If I had a glass of water and I put 1 drop of red food coloring in, it's real concentrated and it's going to eventually kind of diffuse out until after a few minutes, the whole glass is the same color. So diffusion is a process where molecules want to equal out within a given space, and it requires no energy. It just happens. So when we take a breath in, the percentage of oxygen in our alveoli is much higher than the percentage of oxygen that's in our blood coming from our body. So that gas, that oxygen, literally travels through the alveolar wall, through the capillary wall, into the bloodstream where the red blood cells can grab onto it and then take it to the body. Okay? Why is oxygen essential? I'll just, anybody want to shout that out? Why can't we survive without oxygen? Oxygen is, I'm sorry. Okay. Oxygen is the essential component for what we call cellular respiration or cellular metabolism. It's the way everything in our body that works requires energy, and we need oxygen to make that energy. So I'm sure everybody at some point, and this might be middle school, basic biology, if everything's working appropriately, we are in a state that's known as aerobic cellular metabolism. Okay, aerobic, that word means with oxygen, versus anaerobic is without. So every cell in our body, at some point, will bring in basically one glucose molecule and one oxygen molecule. And from those two molecules creates energy that allows our cells to work. And when we're not able to produce enough of that energy, our cells begin to break apart, dysfunction, and when cells dysfunction, organs dysfunction, and when organs dysfunction, systems dysfunction, until it's eventually death. So a lot of what we do in EMS is to maintain that adequate oxygenation in the body. The scenario starts with something that fortunately we don't see here very much, but EMTs arrive for a sick person, unknown problem, which, again, this is kind of common, that what we get paged to and what we walk into are, I shouldn't say often, but frequently, two different things. So we immediately see a man in his 40s laying on his right side on the floor. He's got a makeshift tourniquet beneath his arm and a hypodermic needle laying next to him. First things that come to mind. OD. So, and I'll kind of weave in some of our pre-stuff. If you are the first two to walk in, is the scene safe? I'm going to say no. Can we make it safe? Yeah. So who do we want to call? Get law enforcement. You know, this is tough when we walk into these situations. Law enforcement isn't here. You would be perfectly appropriate if you just said, hey, I got to get some equipment on my car, and you walk out the door and you keep going until the cops get there. With it, kind of through experience, you kind of learn how to manage those calls, but you know, experience isn't going to save you. So I would always advocate that you come in and, hey, this is a potential crime scene. There's a potential for me to get hurt, and what I say potential is a person who was, like this scenario, potentially abusing drugs. Does that mean they're a bad person with intent to harm and hurt everybody? Absolutely not. But when we provide therapy and start to wake them up, they're going to be in an altered mental status. You're not going to be aware of what's going on around them if you're there to help them or hurt them, and there is a much increased likelihood that there could be harm on you. So we back out, we call law enforcement and security. He's pale, cyanosis of the lips, very shallow breathing, and he's vomited, or what you'll hear, we'll use the term emesis a lot. Anyone ever heard of the term cyanosis? Okay. Cyanosis is just kind of have you ever heard someone turning blue? And it's really a poor description, because I think when you see a cyanotic patient, it's it's hard to describe, but I wouldn't say blue like we think of a color. I can rarely think of people that, look like this. Cyanosis, discoloration, more of a darker discoloration around the lips, the face will get dusty in appearance. Cyanosis generally is an indication of lack of oxygen. And to put an example, if I put an IV tourniquet on your arm or put a blood pressure cuff on your arm and pumped it up and then just left it there, we'll see cyanosis. In fact, maybe when we're doing patient assessment, I'll let someone get my arm all cyanotic so you can see what it looks like. Threats to the patient's life, obviously, if they're not breathing adequate, they've got emesis around their mouth. What do we think there's ability to clear their airway? Could there be emesis in there? They're probably not moving enough volume of air to sustain life. So, what do we need to intervene? What equipment do we need to intervene? Obviously, this is airway unit, so we're gonna need equipment to clear that airway of foreign material. Probably use adjuncts to improve airflow in. All right, again, you guys know I kind of use this as a table of contents. And I think I told you, if anybody ever wants these PowerPoints, I'm happy to mail them to you. There's nothing on it. 4 components of respiration. Kind of odd. Don't get tied up on this too much, but you won't be testing on 4 separate components. But number one, we have to be in an atmosphere that has adequate amount of oxygen. So right now, in kind of rough rule of thumb, anyone know the percentage of oxygen in atmosphere? 21%. And that's a good number to go off. We can get down to decimal points with 21%. Anyone know about what percentage of atmospheric oxygen we begin to lose consciousness? 15, 16%? So, on the side, how many firefighters in here? All right, so if I exhale about 4 to 6% oxygen. So when I take a breath in and I breathe it out, there's gonna be about 4%, 5% oxygen. So if someone's not breathing, and I'm doing mouth to mouth on it, and I'm giving them 5% oxygen, and it's enough to sustain life. But yet at 16% oxygen in the atmosphere, I go unconscious. It's not enough to sustain life. Does anyone have an answer for that? Why that is? Especially firefighters. All right. And this is something I struggled with for a while too. So it's not so much a percentage of oxygen, it's what other is taking the place of the oxygen in the atmosphere. Carbon monoxide, hydrogen sulfide, all these other components that can be cellular asphyxiants, right? But yeah, so when we're, just room air is about 21%, and that's something to commit to memory. The vast majority of the rest of the air is nitrogen, and then less than 1% is, other gases, to include carbon monoxide. So we have to have adequate atmospheric oxygen. We have to have an intact pathway for that oxygen to move into our lungs. We have to have adequate rate to move that breaths per minute, oxygen in and out. We have to have adequate depth or volume to allow the air to get past our what's called dead space into our actual lungs where it's going to work. We have to have functioning lungs that the oxygen can move through those alveoli. And has anyone ever heard of the term pulmonary edema? So what pulmonary edema is basically fluid accumulation in those air sacs. And those gases can't travel through that fluid, right? So we have to have structural, intact alveolar membranes. We have to have adequate blood flow to move the blood past those lungs. And that's what creates adequate cellular respiration. And if our cellular respiration begins to fail, that begins to shut down all those systems to regulate oxygen. So a lot of that we get into like these downward spirals. So the upper airway, and I think we might hopefully got some pictures here. So what's the, anyone remember what kind of the dividing line is between upper and lower airways? Vocal cords, the glottis is another term we use. So kind of the vocal cords are what splits upper and lower airway. And we'll be using terms later as we go, such as upper airway obstruction, lower airway obstruction. You know, a tongue, someone whose tongue is relaxed can be an upper airway obstruction. So this image you probably have in your, it's in your textbooks. It's a little bit more zoomed in than what we had previously done during anatomy. So I'll kind of start superiorly with the nasal pharynx. So it's there's structures in there known as turbinates. Again, not too hard, or it's not too important to remember the names of them, but the turbinates, essentially what they do is when we breathe through our nose, they create that turbulent airflow. So the air comes in, it hits all these structures, and it's kind of bouncing and rolling around. And that turbulent airflow, a couple of purposes. Number one, the air is hitting more surface area of your body before it gets down to your lungs, so it's warming it. You've got hair in there and mucus in there that as that air is moved around, any particulates in there are getting stuck there. Firefighters come out, and I use that because everyone has seen it probably at some time. Chief, you fight a fire, and are you coughing for a day or two afterwards? What's it look like?
As long as I put my mask on right away, it's better.
It's black. You know, you're coughing up soot, and it's not, you know, I think in today we really try to reinforce the importance of self-contained breathing apparatus, so we don't do that. But that's your body expelling all that bad stuff. That if it wasn't for your mucus and those turbinates to catch that, all that would end up in your lung. These structures are kind of important to remember because when we talk about nasal airways, I'll grab one in a little bit. No, I'm going to do it now. Bear with me a second.
Get it.
Well, I got it. Oh. I'm just going to grab it, use one out of my vest. I shouldn't say yours. Just grab me one out of storage. What's that? Yeah. Just anything, just something less than a 22 French. So the nasal airways, which I'll show you in a bit, you know, when we look at the nostrils and they kind of go up, right, that we're going to put an airway up the nose, that if we advance it like that, that airway is going up over these terminates and might run a little short, so we actually want to run it straight back. I'll show you in a bit. That's the hard palate. When you lift your tongue up, you can feel it. Rolls back to the soft palate. And then kind of each side at the base of your tongue, you got your tonsillar pillars. Some people have had them removed. You can probably visualize them if someone opens up and say, you can look back maybe with the light enough, but that's about as far back as you can visually see without special equipment. Tongue, big muscle, primarily attached to the hyoid bone. Sorry, right there. This little space here, that's called the vallecula, and that is what forms your epiglottis. The epiglottis is a leaf-like structure, and we'll show you a video here in a little bit, is that when we swallow, that's what closes, so when we eat food, it doesn't go down the airway. Sometimes stuff slips around, and anyone ever taken a drink or eaten someone and forcibly start coughing. So that opening here to the trachea is super, super sensitive to any foreign material. Anything gets in there, you just start violently coughing. Just jumping, this is what we call a nasal pharyngeal airway. This is a French? Didn't know we had an odd number.
It's the one we had the most of.
Yeah, so this is actually a pediatric one. These are termed adjuncts, so airway adjuncts. They help us open a pathway. The nasal airway is something that we can put, I can put it in you guys. It's not gonna hurt. It's not gonna feel good, but we can put it in someone who's fully conscious. We typically don't. But the complications or risk of putting these in, next to nothing. But if someone's what we call in an altered mental state, not responding very appropriately, and we need something to kind of allow them to get oxygen a little bit better, this is a really quick, simple tool, takes about a second to put in. With any airway adjuncts, we lubricate them generously. But the airway, if I went in like that, you can see how it's gonna sit. We want the tip to actually end up right here. So by going straight back, we bypass a lot and we're able to get that airway to line up more appropriately. And again, we're gonna focus on indications and how to put them in a little bit later. So this is where your larynx is, the voice box and the vocal cords are sitting there. And so that's kind of the structures of the upper airway. The hypopharynx, hypo just means lower end of the oropharynx, nasopharynx, hypopharynx, oral meaning mouth, nasal meaning mouth. The esophagus sits just posterior to the trachea. The esophagus is actually closed flat. It's not like a tube that you can see. So at the upper airway, I found a little endoscopy video. So here they're gonna put a camera down someone's throat. So what we're looking at here is you're basically like I'm laying like this and they're going in this way. So the top of the mouth is up here, that we're just starting to venture down into the airway. So what we see here is a lot of tongue, and you can start to see the image of the tonsils on the side. I'm going to pause it there. So that little veiny thing, this is the epiglottis. That's that valve that closes. And on a side note, notice the blood vessels that are in here. Has anyone ever heard of epiglottitis? It's more common in pediatrics. Like, I don't think I've ever seen an adult with epiglottitis. I'm not going to say it can't happen, but epiglottitis that swells, it gets large, and we have to be super careful doing airway management, because if it's vascular, blood vessels mean ready supply of blood flow, and you got to remember, we got red blood cells that carry oxygen, you got white blood cells that fight infection, and you got the white blood cells can activate inflammatory systems. So if someone's got an irritated epiglottis and I go in there and tap it with a tool, it will just it can swell very rapidly. So it's a solid structure. I'm gonna see if I can back it up just a bit. So this is, you can just kind of start to see the tip of it here. And this is something that you probably visually can't see by looking at someone's mouth. So we're already kind of back there a little bit. And what they'll do is they'll pick that epiglottis up to where we can see the vocal cords or the glottic opening. So right here, this is the glottic opening, this is the passage to your trachea. There's going to be two little whitish colored lines here. Those are your vocal cords. That if this guy was humming and talking, we'd actually see him opening and closing. So visualized airways, when we talk about them, visualized airway means a provider has to go in with some type of visualization tool. And we have to look for that, and you have to put the breathing tube in that slot. Versus a non-visualized, we just can literally blindly put it in. And see if we can look at the esophagus a little bit. So the esophagus is gonna be underneath here. Pretty, isn't it? And now what he's doing now is he's just advancing the breathing tube. And so it looks really big. That breathing tube is probably just a little bit bigger than, this is what it is right here. So it's not a super big device, it's just what you can in there. Looks big. Okay, so exterior structures, this is the, more of the cartilage that kind of holds it together. So we can see this, this is affectionately known as the Adam's apple, if you will. So hyoid bone, which you can't feel, it's kind of up here in the soft tissues. Thyroid bone, that's the prominent part of the voice box that you can feel if you grab it. Immediately below that is going to be your cricoid cartilage. In fact, if you find your larynx, you'll feel there's a little, you can almost feel this little notch. So I try to set my finger on that. And if you run your finger down that larynx, you'll feel a little indentation. And that indentation is the cricothyroid cartilage. So thyroid, cricoid, the cartilage in between. That's where they would try to access for like a surgical airway, to do a cricothyrotomy, if you will. As we move down past that, we get into the tracheal rings, which if you feel back a little bit, and it's super uncomfortable, kind of feel your windpipe here, you can actually feel bump, bump, bump. Those are your cricoid rings that hold, they give it structure so it doesn't collapse. Now on the back side, so this image, you're looking at it here from the outside. If you turn me around and you look this way, this is what you're seeing from the inside. So arytenoid cartilages, notice the cricoid rings, they don't go completely around, they're just kind of C-shaped. And the reason they don't go all the way around is because right here along that runs your esophagus. So can you imagine trying to swallow food and it's got these rigid rings to go down? This is what allows that esophagus to bend into essentially your trachea as we're eating and swallowing. And I should say trauma, especially direct trauma to the neck, and I'll just use kind of a violent example, but someone's driving a car, doesn't have a seatbelt on. They immediately stop from a tree, they go forward, and that steering column catches that neck. That can break or compromise those cartilage structures to actually crush down and give it'll block the air passage. And not only do you have the structural damage of that thyroid being crushed, what happens to any tissue when it's injured? Swells. So you're going to have the immediate compromise, and then over the next 20, 30 minutes, immediate swelling into that area. Lower airway. So we were kind of previously talking about the upper airway structures, and here's kind of a cross section, again, showing that the cricoid ring and then the smooth muscle of the esophagus. But there's lining that goes down your trachea, so you've got mucus cells in there that even down your trachea and into your main bronchus tubes, there's snot in their mucus that is designed to catch any particulates, some little cilia or hair in there. But as we go down that windpipe that hits the juncture of the tubes known as the carina, in fact, when we talk about suctioning, that sometimes to do deep suctioning, we actually put a suction tube down and it hits that point, you'll know, as you're advancing that catheter down, you'll feel it stop. We don't need to push any further, that's where we start suctioning and then suctioning way out. That then splits into the right-left bronchus. Side note, the right main stem is a little bit more of a straight angle from the trachea. So if you're ever with crew on the ambulance and they're putting an airway in, and then you're gonna hear them listen to make sure they've got lung sounds, and you hear them say, I think we right main stemmed them, or it's too deep to the right. So when we pass this tube, you know, this tube should go down and stop about there. And this is like super elongated, like your carina is like right about here, so it's not that far. But if we're advancing that tube and it hits that, it can pretty easily go into the right sometimes. And we confirm that by listening, and you hear that air on the right side of the chest and the left, nothing. Then all we do is you just back it out and then recheck. Not that you guys gotta do that, but you may be assisting with it, which is why I want to touch on it. I can't see the time, so someone's gotta let me know if we're getting close to the hour mark, okay?
You're good.
We talked about the mechanics quite a bit last week, but does everybody kind of understand that vacuum principle? So if I take a container, close it off to atmospheric air, and I open it up, the air pressure in that container, or I make it bigger, that air pressure is lower than the air pressure in the atmosphere. So if I open it, create a passage, air will just passively move in there. So that's what I'm doing, is that when my brain initiates me to take a breath, it's active. All my muscles contract. My chest muscles, they contract, open up my rib cage, my diaphragm contracts downward, opens that up, creates a bigger space, and air will just come into the chest. When I exhale, that's passive. It means the muscle just relaxes, my chest cage gets smaller, the diaphragm gets smaller, and essentially forces air out. So when we talk about negative pressure, right now we are all breathing on negative pressure. When we put tubes in, we now are switching them to positive pressure. We are having to force the air in. You will not be tested on the pressures, okay, so you don't need to study those numbers. Control of respiration, I know we talked about this a little bit, but the brainstem, remember, very, very sensitive to changes in your pH of your, it's actually looking at pH of your cerebrospinal fluid. So when my pH in my blood changes, it's almost an immediate change to the CSF, we call it cerebrospinal fluid. Cerebrospinal fluid is, if you look at your brain and spinal column, it is a super, super slippery substance that pretty much bathes or surrounds it. It serves a couple of functions. Chemical messenger, there's sensors in your brain that sense any changes in that pH. It also provides some cushion. When we talk about trauma later, with like skull fractures, fractures that open that separation of cerebral spinal fluid in your body, a fracture site, you can actually get a CSF leak. Ever touch cerebrospinal fluid yet?
Have I?
Yeah.
Oh, yeah.
The slipperiest stuff I've known. And it's super clear. So anytime we see water coming out of ears, nose, it's, especially with a head injury, they've got an opening where cerebrospinal fluid is leaking out. Now, sounds bad, but in the realm of things, it's actually, it's not going to save them, but it's allowing pressure to get out. okay? Where if it's closed and that skull hasn't fractured, that pressure that's building up has nowhere to go but the displaced brain tissue. So our pH drops, or I'll even simplify it, that we start to accumulate carbon dioxide, a waste product of cellular metabolism. And we increase carbon dioxide, that drops our pH, our body senses that, makes us breathe faster. And I think I used the example that if we all went outside running right now, let's all go for a run. And everybody would have varying distances, but you know, for me right now, not having worked out, I don't know, I maybe make it up to County W and you're breathing pretty hard. And that's because the act of running requires a lot of energy. Energy creates more waste product and byproduct, so I'm gonna get a rapid accumulation of CO2. My brain's gonna sense that, and it's gonna make me start to breathe harder and faster. I'm sure anyone who's done any exertion, you see it. Now, you can get your body so where it's not, it gets more used to that, and that's where athletes and people who exercise every day don't puff and puff as much as like I would. But I'm not looking at you. You got other organ systems that make up for it.
Yeah, right.
Something in your book, and I do want to touch on that some COPD patients rely on hypoxic drive. So this is, I don't think they're teaching it anymore, but what really triggers us to breathe is our carbon dioxide level, okay? So right now, we start to get increased carbon dioxide, we breathe faster. We don't have enough carbon dioxide, we breathe slower, okay? That usually it's like your emphysema, your chronic smoker patients that smoke cigarettes and their body is getting bombarded with carbon monoxide every day. Those sensors begin to get dulled up. And I think if you took a carbon monoxide sensor and put it in your garage, how long do you think that sensor is going to last? Right? It's going to wear out much quicker because you're constantly bombarding with CO2. So that's what happens to the body, basically. That then your body, instead of measuring your CO2 levels, starts to measure your oxygen levels. So it's a backup system. It still works, but it's not as efficient. So by theory, somebody who switches to that system, if I give them high flow oxygen, their oxygen levels start to get up to what we would consider normal, but to that person who's used to being low oxygen levels is now high, can actually tell their body, you don't need to breathe so much, we have enough oxygen. So they can eventually just stop breathing. Now when I say eventually, this is nothing you're gonna see in the field, okay? If someone has COPD, number one, we have no way of knowing if they're on a hypoxic drive or they're breathing over. We don't know that. If they need oxygen, give them oxygen. And if they stop breathing, it's probably not because of the oxygen you gave them, it's probably because their underlying disease has just gotten to that point where they will stop breathing. So just if you hear that term or you ever hear an older provider say, don't give them oxygen, they got COPD, no. You're not gonna hurt a COPDer or have them stop breathing just because you gave them oxygen. Now, we put them in a hospital bed and they're sitting there for 12 hours, 24 hours, and they got that. That's gotta be monitored a little bit more over long term. But for the short term that we're with them, don't worry about oxygen effects with hypoxic drive patients. Hypoxia. This is a term you're gonna hear, hypoxemia. Hypoxia is insufficient oxygen. Hypoxemia is insufficient oxygen in the blood. We use those terms interchangeably. So if I were to say the patient's hypoxic, that means I probably did an oxygen saturation and it's very low. So we need to get them, you know, hypoxic people need oxygen therapy. And this is where that as we go through the class, we start to assess different things to determine what level of therapy we have to do. Does that make sense? I don't want to get you thinking that you have to differentiate emphysema from asthma from pneumonia at this point, that they're having trouble breathing. And this is the therapy we're going to administer. Cyanosis, chat about that. So again, just kind of a description. Usually this is probably some of the most common cyanosis we see is, and it's rare, but we can see it in the lips. If you know of someone who's a chronic smoker, especially kind of late stages, that when you look at their nail beds, there will be bluish purple color. So now you'll be watching for it. Letter D looks like a corpse, pretty much. That's very extremely late stage. I don't know, and I kind of looked, you got any other examples where you may run into cyanosis that you guys have seen on a?
Well, I'd say the purple lips is not necessarily fully indicative, like, of the smoking, but also, like, if you're cold or anything like that. Like, my daughter gets purple lips all the time. We're like, are you dying? No, she's not dying, it's just how they are. I would honestly say probably skin.
It's from lack of oxygenated blood. And I'll tell you, I know people may have heard that venous blood is blue and arterial blood is red, and then venous blood, once it hits the air, it turns red. No, the blood is red. Okay, there's no, if you have blue blood, you have methemoglobin, something like that. Don't ask me to pronounce it, but, no, blood is red, okay? And I don't wanna, because this is an EMT text, I don't wanna, when we go into part 2 EMT, right? We'll dig into this a little bit more, but I don't wanna bog you guys down at this time too much. Pulmonary ventilation may be impaired, so again, just kind of differential, I'll kind of touch on each of these. So, interruption of nervous control. This can be structural, so I dive off a boat dock in about 2 feet of water, and I sustained a cervical cord injury. That cord is damaged, and all the systems that from below that damaged site that are innervated by those nerves are going to stop working. So it may be, if it's high in the neck, it could stop me from being able to expand my chest and contract my diaphragm. So you can't bring air in if you can't expand your chest, that you lose that muscle control. So I can even there's other disease processes, and I'm trying to think, has anyone ever heard of a condition known as myasthenia gravis? Okay. For impulses to get essentially from my brain to the end of the nerves, there's a chemical messenger that jumps across those nerves. That when you look where nerves connect, they don't actually touch. That there's a gap between them. So if I'm trying to get an impulse from here, from this elbow to this elbow, and I've got one nerve ending like this and another nerve ending sitting here, they're not actually touching. There's a gap. And little chemical messengers we call neurotransmitters go across. What happens in some kind of autoimmune diseases or like myasthenia gravis is that those chemical messengers don't work. So they don't transmit, which means impulses can't go that way. So that would be an example of, nervous control. Obviously damage to the chest cavity, so if I have direct trauma to my lung or to my ribs. So broken ribs, and I know we had talked about this previously. Does a broken rib immediately threatening to life? No. Depending on, where you're at in your stage of life, you take a guy in his 20s that gets launched off his motorbike, breaks 3-4 ribs, it's probably gonna be okay. You take a 94-year-old female who fell and broke 3-4 ribs, that's probably going to be fatal. So rib fractures, not only is there a potential for them to actually rupture lung tissue and collapse the lung, if you will, it's excruciatingly painful to where they don't want to take deep breaths. So they just take short breaths, which means they're not moving adequate volumes, and they become hypoxic over a longer amount of time until they just go into respiratory failure. Loss of patency, increased airway resistance, so if I take that airway tube and I swell it like asthma, that's an increase in resistance. That's harder for air to get in and out of those airways. And airway patency, and that can be I'm choking on a foreign object, my tongue is occluding my airway. So these are all things that can impede that airflow.
If you, like, hypothetically, you break your ribs or whatever, like you said for an older person, like if they break their ribs and puncture their lung or something, can they still, like, breathe for a certain amount of time
Oh,
before
yes.
it's, like, life-threatening, or is it like, you
Yeah.
can't breathe?
No, so you can have an open chest injury where I shoot you with a gun through the chest. Bullet goes through the skin, fat tissue, muscle, through the lung, out your back, right? We have a structural hole. That's an open chest injury. That, as it breaks, and remember when we were talking anatomy, you've got two linings. You've got a lining on your chest wall, and you've got a lining over the lung. So it's gonna break through both of those openings. So when we breathe, air is gonna go in to our lung, but it's gonna go out that hole. And you start to get air building up in your chest cavity. And if that hole is big enough, so I shoot you with a big enough caliber, you can actually get what's called a sucking chest wound. Where when you take a breath, you're also sucking air in through that hole. Okay. That you start with a small area, and with every breath, it starts to get bigger and bigger and bigger. And with some chest injuries, it can just kind of stop and hold at a point. Other chest injuries, it can just keep getting big and big. So as you get air that builds up in that chest space, it begins to push down or displace portion of your lung. Okay, that's called a pneumothorax, air in your chest. Pneumo being air, thorax being chest. If that air pressure continues to build up and begins to collapse more lung, and now it's filled up to the point where now it's starting to push on your heart and the other lung, that's what we call a tension pneumothorax. And that's immediately threatening the life, and we have to, well, that's where you need ALS intervention. We have to basically introduce a needle to let the air pressure out.
So about how long do you have of breathing time, I guess, before?
Varies depending on the rate, the volume. So that was open. You can also have the same thing with a closed injury. So I hit a steering wheel with my chest, and it takes my ribs and snaps them, right? And that snapping actually ruptures lung tissue. There's no hole, so I'm not gonna have a sucking chest wound, but I can still have that pneumothorax. And another term, another term that we'll hear is hemothorax, which is blood in the chest cavity. So usually with the trauma, it's a combination of a pneumo-hemothorax. Got a little of both.
Yeah.
Jumping ahead a little bit, but you take like emphysema. Remember where we got all these little balls, these air sacs, alveoli? And in emphysema, those walls kind of start to break down, and you can get basically this big blood popcorn looking thing in the lung. That by them coughing, because those alveolar walls have become so destroyed, that just coughing can burst them. So now air can leak out through that. So it doesn't have to be a traumatic, you can get a spontaneous pneumothorax. And some of those we can pick up with a stethoscope. And what I will tell you is, take my lung, that usually it's, I think, Steve, I don't know if you've been up on the readings, usually you need to be at 50% of your lung collapse before you can start to hear it with a stethoscope. So generally 30% or less, they don't do anything. They'll get a chest x-ray, they can see you got some air in your chest, and they're like, we're just gonna watch you. Your body will heal.
Especially if it's lower, because you're not normally using that lower lung anyway, as your reserve tidal volume. So it's hard to hear, I would agree, it's very hard to hear, unless it's a large lung.
Well, I can't hear anyways, normally, so it's something and we'll get into kind of, we'll spend some good time on just specific chest trauma. Did I answer the question?
Yeah.
Okay. Yeah, we kind of talked on this stuff already.
We can take a break if we want.
Thank you.
Because-
What do you put in? I know what it is, right? What do you want? It goes over this.
Nope, nope.
All right, we'll just, structural differences, structural physiological differences, and when we talk, like special patient populations, a lot of time we're referring to pediatrics and geriatrics. Geriatrics, again, kind of subjective. Usually when I hear the term geriatric, I start thinking 75 older. I will tell you that here in the district is that a lot of our geriatric population is, I would say, from my experience, the health is, geez, surprisingly well, compared to the area I came from. So, just doesn't necessarily mean that there's more advanced disease, but geriatrics, as we age, are things like how much oxygen we need, it begins to change. So pediatrics, or I should say geriatrics, they tend to get more rigid, meaning things aren't as elastic, they don't stretch as well as they used to, versus pediatrics can almost be sometimes too elastic. And pediatric airways, and when I'm referencing pediatrics, it's generally thinking like that 12 and under, pre-puberty, and the younger they are, it's a little bit more structurally different, but you know, if I take a 1-year-old, their tongue is disproportionately larger than what an adult is. So, you know, and that's why, you know, we always worry about kids with airway obstructions from putting things in their mouth because they got, you know, a big tongue that takes up a lot of their airway. If I take a baby's head and I were to tilt it back too far, you can actually, because their trachea isn't really rigid yet, it's still performing, that you can actually almost pinch it off like a straw. So it's a little bit more gentle manipulations with the manual airway maneuvers. And we will practice with some babies, so just kind of a diagram, and this is showing with pediatrics, tongue is a little bit larger, takes up more area, their nasal pharynx isn't as large and developed. The epiglottis in kids protrudes a little bit more, cricoid cartilage. So a lot of the body's still developing in that stage. Okay. So these are showing just some traumatic, and again, sorry, I warned you, we would see some traumatic type pictures. But so the patient on the left, that's a burn patient where at this point may have an intact airway, but can you kind of see up on his forehead where his skin is sloughing a little bit? So this is for sure at minimum partial thickness burn, and we haven't gotten into that, but it's into the dermal layer. May even be progressing into a 3rd-degree burn, not sure yet. But the heat was enough to cause damage to his face that it wouldn't take much for that heat to get into his airway. And again, I said, what happens with trauma? Swell, right? So if this patient, if we were talking to him, and he's talking to us with a good clear voice versus if he's starting to get hoarse and raspy, you know, that hoarse and raspy is telling us we have an impending loss of airway. So that's someone where if you don't have an ALS unit en route, we need to get them en route because this person's going to need to have a visualized airway to secure that, or that airway will close up. The patient on the right, structural damage, I don't know what caused this. I can share with you that you can, the upper airway structures can sustain pretty significant trauma and the person still be very viable. I don't know if I'll do this or not, but I had a video of a male patient that sustained a shotgun blast to his face. And I haven't seen it in a long time, but a common, not common because we don't see it all the time, but people who attempt to commit suicide with a shotgun or rifle is that the distance from the trigger to where they support the gun is, you're stretching quite a bit. So if you can imagine, if I've got a barrel here and I go down to squeeze that barrel, because I gotta reach down, I'm gonna move that gun forward, right? So it's not going to impact my brain and brainstem for immediate death. What it's gonna do is it's gonna take off the jaw, the palate, and a lot of the airway structures. Those are a little bit more difficult, where we have to, you gotta get your hands dirty. We have to try to find airway structures to put airways in. A lot of suctioning. And honestly, if we're faced with that injury and we don't have a lot of those tools at the EMR level, what's the immediate threat with large blood loss into an airway? What's it?
Aspiration.
Aspiration, bingo. So with someone who's got large structural damage like that and they're bleeding pretty quick, what's something we can do to prevent that aspiration? Yeah, get them on their side, or this is a rare instance where we may transport a patient actually face down or have them lean over a pillow. Otherwise, kind of a rule of thumb is we don't transport patients in a prone position, ever, unless it's an airway type issue. And again, don't want to give war story, but this happened to me once where a person took a .22 caliber gun into their mouth, and we got there and the person was sitting up, kind of coughing, gagging, not very cooperative, but had attempted to commit suicide, got a shot off, family called us. So the bullet had not hit vital structures in the brainstem, so they're very much alive. But with the amount of blood that was coming out, we had two options. And this patient, anatomically, I can tell you, paint a picture, about 5'2", north of 400 pounds. So kind of short, wider, kind of big neck. This is, for anyone who has to put an airway in, this is going to be what we call a difficult intubation. So we have two options. We can put this person to sleep, paralyze them, and hopefully get a breathing tube. Or put them on a cot, have them lean over some pillows, and get them to the hospital where we've got a whole trauma team and anesthesiology. And that's what we did. And the patient did have a good outcome. But yeah, things like this, and this could be multiple stuff, and what we're just seeing is the soft tissues of, looks like the cheek have been opened up. I don't know structurally if the jaw is still intact or not, but aspiration is aspiration or tissue blocking that airway. So it might be enough of just moving that tissue out of the way to allow the passage of air. 10 signs of an open airway. So air can be felt, heard moving in and out of the mouth and nose, patient speaking in full sentences, and the voice is normal. So these are all indicators that a normal voice is telling us that our vocal cords are intact. Okay, hoarseness of when someone's talking hoarse can indicate that there's swelling near those vocal cord structures. Speaking in full sentences. So again, I use this example a lot. If we all went out running, let's just go, we'll go, I don't know, we'll run to the Bear, come back here. That's what, half mile, there and back. And then I'm gonna have everybody read a paragraph. So how good can you read when you're, right? So when we're doing patient assessment, a lot of times when we're talking to a patient and we report, like if you were to tell me in the ambulance, they're speaking in one-word sentences, meaning 1 or 2 word sentences, that I can only get 1 or 2 words out, then I have to take a breath. So we said, Ian, how's your breathing today? And you said, it's not doing very good. That's 2 to 3 word sentences, and that's very, very concerning. So if you're able to get a whole sentence out, that generally indicates good respirations. And air, we haven't gotten to assessment. When we start listening with stethoscopes, airflow should be quiet, that we shouldn't hear people breathe. I know my wife can hear me breathe because she gets annoyed by it sometimes. But really, I mean, we all know if you're sitting next to someone and they're, it's annoying, but we should not hear sounds from people breathing. Abnormal sounds, so upper airway sounds. These are terms we'll hear quite a bit as we're talking, especially jumping into patient assessment. So snoring. Snoring typically indicates airway obstruction by the tongue. It can be snoring like we're hearing someone sleeping, or when we get into almost like agonal breathing. And I did find when Saturday, I've got a body cam footage of a cardiac arrest. And so we'll watch that. You can hear them, that agonal kind of snoring sound while they're doing resuscitation. Gurgling, that's kind of well, if I took a drink of water and didn't swallow it and laid on my back and tried to breathe, gurgling is kind of wet. There's secretions, fluid, vomiting in the airway. Stridor usually indicates a swelling, and the stridor is a it's a pretty ominous sign. It means we're getting some airflow, but it's not real good. And crowing, I've never heard of that term. Steve, you know what crowing is?
I do not.
Okay, then we're gonna skip it. Signs of a blocked airway, stridor, all these, you know, the gurgling, the stridor, all indicate that we don't have an effective passage. If a patient can't speak or make any sound, that is a complete airway obstruction, and we don't do anything else until we can get that airway passage open. We'll learn about that Saturday. Yeah, I touched on it first. So, opening the mouth, that if we've got to open somebody's airway, I'm gonna grab, bear with me a second, yes. So first off, as we get into this, we're typically talking about someone who's not of total mental status, right? So if I'm talking to you, I'm not gonna go in and open your mouth, okay? So someone's laying down, or someone's unresponsive, we need to assess their breathing. First off, it's hard or impossible to assess them unless they're in a supine position. So we want to get them on their back if possible. And I might be jumping ahead a little bit, but one of the most common maneuvers we'll do is called the head tilt chin. So person's laying flat, I don't know if everyone can see it here okay, is we essentially just take their head, well, like textbook, it's grabbing them by the chin, grabbing their head, tilt their head back, and bring their chin forward. So what we're doing is we're actually, that maneuver is just pulling that tongue up off the base of the airway. Remember that tongue is attached to the hyoid bone, so if we bring it back like that, it should open that airway. The mouth is closed, and what we got to do, if we got to open it for some reason, like to suction them or things like that, this is showing what's called the scissor technique. We're just taking our fingers and crisscrossing them on the upper and lower teeth to get their mouth open. Like that. And we do that in case they wake up and bite down. Our fingers, we don't want to put our fingers in and open, because if they bite down, yow. And then just, you go in the hospital, get antibiotics. So scissor technique to open the mouth. A lot of times if we're, this is called a rigid suction catheter. So I want to suction somebody, and we'll learn, we'll measure it, we'll open their mouth, put it into that point, and then suction the airway out. Head tilt chinlet, just did that. Pediatrics, I'm gonna touch on the pediatrics on Saturday, and this is, okay, baby, we have a baby over here, right?
The little box.
I mean, a full,
Oh, it should be in there, yeah.
if we laid baby, this is kind of, the baby's laying flat on the back, the head, I can't push it forward, but it's gonna be almost including the airway bringing forward. And if the baby's flat on the back, just anatomically, to do the head tilt chin lift, we can do it, but it's not as aggressive as it is with an adult. A lot of times with little babies up to probably school age, that if they're flat on the ground, we'll just do it here. Baby's flat on the ground, a lot of times by just putting some padding underneath those shoulder blades is enough to open that area. So that's kind of what that one picture was describing. Now, the ear to sternal notch, and I'm really surprised that they're teaching this now, and I really like it. So this is optimal airway position. And has anyone ever heard of sniffing position? Okay, sniffing position is kind of thinking like head tilt chin lift, right? But sniffing position is actually, if you think about it, it's springtime, snow's gone, it's 65 degrees out, you walk out in the morning on the dock by the lake, got your cup of coffee, and you kind of put your head out and you sniff. So head out, sniffing, that is sniffing position. And anatomically, to line up all those vectors of the airway, if you will, we want to try to get our ear canal in line with our sternum notch. So right now, my ears are more in line with my shoulder blades, so bringing my head forward opens up that passage. That inside an airway, so if this was an adult kid, you've got your oropharynx goes back to your hypopharynx, and then your trachea is actually up and forward. Okay, so it's almost like three corners that air has to go over. By bringing the body up a little bit or bringing the head forward a little bit, we're bringing those ears in alignment, and it's taking those hard corners and kind of straightening them out. So this is ideal position. We usually don't do this maneuver so much on pediatrics. The maneuver that we call it a ramping maneuver. We do it on bariatric patients where, well, like the patient I told you, 5'2", 400 pounds, if you laid them flat on their back, the sternal notch is basically here. So we have to bring their body up and their head forward to try to get that into alignment. If you're assisting the ambulance and you hear say, we need some pillows, we gotta do a ramp on them, that's kind of what we're talking about. We're gonna try to anatomically bring those into alignment before we try to put airways in. Now, if this is a trauma, so car accident patient, this is maneuvers we don't do if we're worried about cervical spine or injuries to the neck. There we got to try to keep the neck as in line as we can. So we really can't do these ramping ear sternal notch. There's a common that you will see us do. So if we're worried about someone's neck being injured, and we really don't want to crank and do that head tilt chin lift, we're going to do what's called a jaw thrust maneuver, and it's really hard to simulate on a mannequin, and it's hard to simulate on you here. Everybody has muscle tone, and you will normally not let me do a jaw thrust. So what the jaw thrust is the angle of the jaw here. We're trying to get behind here and push that jaw forward. The tongue is attached to the jaw, so if you do this basically, by bringing the jaw, we're bringing the tongue up with it. So someone who we're concerned about a neck injury, I can kind of get up behind them, put these two fingers on the angle of the jaw, and try to lift it up. It's tough. And you guys are all going to get hands-on doing this here. It's the same with pediatrics. Suction. All right.
a question quick. If you've got someone in a collar, does that kind of push their jaw forward automatically?
Well,
if they're in
you
a
know, I mean,
collar, or-
collars, you know, we put collars on, but if we have to manage the airway, we take them off.
Okay.
And this is, I apologize, I have not taught an initial EMR course in a very, very long time. So I'm trying to catch myself of wrongly assuming that, oh, you guys, this is, you know, you did this when you took the class 2 years ago, right? So, that's why I kind of feel like I'm bouncing around a little bit. But if we're worried about a cervical spine injury, so someone's in a car accident, they're unconscious, they're gurgling, we need to manage their airway. Can't do head tilt chin move, so we do our best to get them supine. But one thing you're gonna learn is C-spine stabilization, which is basically where we're just taking the head and holding it still. If you've ever seen pictures of a car accident and you see someone just standing there like this, it's not because they're nervous, that's their job, is to just hold that head still. When we start to get to critical patients, sometimes you're having to do more than one thing. So there's 2 of us there and we've got 8 things to do, which means I have to do 2, 3 of them myself. So I'm gonna hold C-spine and open that airway at the same time. And then throw in, now I gotta breathe for him with that mask over there. So now you can see where it's getting complicated. And obviously people don't collapse on a table. And if you can't see too much, I can keep a neck in line. And a lot of times I'll hold stabilization with my knees. Yeah, I'm not squeezing. And you gotta remember, stabilization, it's not tight, I'm just preventing it from flopping around. Okay, so stabilizing means I'm just kind of holding it still. It doesn't require a lot of pressure, but now I've got both hands free to manage and manipulate the airway if I have to. It's not good, this is why I don't wear designer clothes or expensive clothes when you go to things like car accidents. And if you do, just get ready to sacrifice. But suctioning is a way for us to clear an airway of foreign material. And we have a pile of options. On the low end, we can just suck it out, which we don't teach you, we don't do. That's a low end option. With babies, you've got, I mean, for those that have kids, you've probably done it multiple times. How many of you use the bulb syringe? Yeah, so we use bulb syringe with infants all the time to clear airways. We have, I think what I was going to get on the pictures here. So this is every ambulance must have an onboard suction. So this is attached to the ambulance that when you get in there and as we play with it, you look around, you'll see every ambulance has to have this. It's required. Has to be tested. We have to make sure we can generate enough suction with it. Then we have portable units. A lot of times they look like this, super lightweight. And it's usually got there's a power unit that creates a suction. And that pulls through this tube. There's a canister to collect, and then suction tubing that goes out to whatever tip or end we want to put on. This is more of a modern version. This is probably early 90s. And you guys can see later, you know, before we go tonight, we'll let you come. This is about 3 times as heavy as this.
Maybe the 80s too. Maybe the 80s too.
Well, did you ever use the Emerson resuscitators?
No.
Okay, I have one, and it was literally a briefcase, about that big, that had the oxygen and the suction in it, yeah. So portable units, and every ambulance is required by law to have a portable suction unit. Then you've got other manual suction devices like this. Now this is something that some EMRs carry in their packs. It's operated by, you generate suction by doing this. They're tough because you really, and there's a couple different proprietary, different brands. This is probably the most common that we see. Not super effective, but you can open a mouth, get that in there, and get some big chunkies out.
Do you have to worry about like, when you're doing this, do you have to worry about it forcing it through at all?
No, because it only draws here, yeah.
Okay.
And the whole, just because I get asked every time, they do make commercial made, looks like a toilet plunger. If someone's choking, you put it on them, and I haven't seen any data on it, but I've had people that have read data that supposedly the things work. I don't know, I've never tried it, but.
What are you primarily sucking out?
What's it?
What are you primarily sucking out in a blocked airway?
Anything and everything. Saliva, vomit, blood, those are probably the big ones. Every time I'm doing, if I'm doing advanced airway procedures on someone, I suction every time, whether they vomit it or not. Even, well, not as much as this class, but you can get, we call it epiglottic camouflage. That if I go in, we use, it's called a laryngoscope. It's this kind of blade with a light on the end of it. We go in, can pick up. That's what we use to look in the airway. That if someone just collapses, you know, you've got saliva and secretions in your mouth, everybody does. And a lot of times I can create a film that when I go in, everything just looks pink. I can't see nothing, so I go in there and I just hit it quick with a suction. That epiglottis flops down. And when you're going in and doing the visualized stuff, we're looking for these structures. It's like reading a map. Okay, so if I'm with the patient and they've got gurgling or any kind of, sounds like wet or, you know, junk in there, we just suction it. Don't ask. If I've had patients that with like nosebleeds, they're bleeding really bad and, you know, it's going down the back of their throat, you know, if they're appropriate talking, a lot of times I just hand them and they, you know, they'll put the suction in and do it too. If they're capable of doing that, fine. So different devices, and those are the actual suction units. But we've got different ends that we can use to suction. So I'll pass these two around. These are the most common. That they've got multiple different names. There's rigid suction catheters. Aren't these perforated, or do I gotta actually bite them?
Do you got those?
Yeah.
Yeah, no, they're not perforated.
So these are the rigid, and sometimes we use proprietary, this might be called a Yankauer. This is what we call a Ducanto. So here in the district, these are the hard suction catheters we use. The old Yankauers, there's a little bit larger of an opening, so these should pick up some larger material. A lot of times if they've got a chunk of food or something, you gotta grab it, pull it out, get it off, go back in and get more. This one's got a little bit bigger of a bore, we can get kind of more volume or bigger chunks through it. But when you put these in, these Yankauers, some of them got like an air inlet we gotta cover. So if I've got suction hooked up and it's sucking and I put it in, nothing's gonna happen until I cover that hole. That creates a suction. Whereas the Ducantos, these have no hole, I put them in and they're already sucking right away.
Why does it have that hole then?
Hmm?
Why does it have a hole, just so you can control it when you want?
Yeah, it's so, when you suction, we typically suction on the way out. So we advance the device in, apply suction, and you kind of sweep it and you suction on the way out. Otherwise, if suction is going when we're going in, there's a chance that you get stuck to a cheek or, you know, you're kind of, you know, we got to get down to that lower airway where that fluid kind of accumulates. Like, remember that airway video? There's a lot of saliva and stuff in there. You know, we want to get down into there, start suctioning to get it out. And you will literally hear that as you're suctioning that, it just clears up. We don't hear the sound anymore, okay? So those are rigid catheters. And you may hear another term, what I don't know what your text calls it, we used to call them whistle tip or soft flexible catheters. So this is what they look like, they're very pliable. We can use these on, this one gets hooked up to the suction tubing, and this is the what we have to cover to create suction. So, we can do it with little kids where we don't wanna put something that big down. I can run this down a breathing tube to suction if material's in there. When you learn about your iGel airway, there's a gastric port that we can run this down to suction out of. Just more flexible, but whenever we are introducing the suction device in, we're gonna remember two landmarks, the corner of the person's mouth to their earlobe. Okay, so for me, I would put the tip at my earlobe to the corner of my mouth, and I typically grab it, so that's my mark, that's how deep I'm gonna go. So if we're just suctioning the airway as the EMR, that's how deep I would go. I mean, some people might, obviously a kid, I'm only going maybe that deep. Everyone's a little different. And if you're off by a couple millimeters, it's not the end of the world, okay? So when we suction, kind of another, and this is an important test thing, is we want to make sure we're not suctioning for more than, I'd have to look at, every book's a little bit different, but anywhere between 10 to 15 seconds. Okay, so if we're suctioning, we're getting a lot of stuff, and 15 seconds is up, take it out, we might have to breathe for them a little bit, because as we're suctioning, we're not oxygenating. Okay, I'll pass this whistle around for you. So, different situations, obviously if someone vomited, and we got a lot of chunks in there, I'm gonna use, the bigger bore. If it's just little secretions, I might use some, finer equipment, but for us, when we're gonna suction, we use that Ducanto, that's all we use. Okay, so the text is more than 15 seconds at a time for an adult, 5 seconds in infants and children, so. Now, in a test, here's the one thing I'm gonna tell you, that it's in the textbook, it's in the standards, that when you suction someone, as soon as you're done suctioning, you're supposed to put that suction tip into some sterile saline to clean it before you resuction. I have never done that. When I'm suctioning, the patient's in really bad shape. And reintroducing something that was just in their mouth again is the last thing I'm worried about. Okay, so you'll read about that step in your text, and that's something that I just have to dig in and say, we don't do it. When we're suctioning airways, there may be times where we're actually just taking the suction tubing, the biggest bore, and we'll put it in their mouth while we're managing and just bringing blood out. So we have to, it is essential, it is vital that we open that airway to suction. So if it sounds like they got secretions or gurgling, suction. Something we gotta do it, and don't waste time, don't be shy about it. Suctioning is not a painful procedure for the patient, but what really sucks for the patient is when they can't get oxygen. So really, we're gonna teach and get you guys comfortable with aggressive suction. So here's just going through there, measuring from the corner of the mouth to the tip of the ear. And with the yank cover, they insert it first, then apply your suction, and suction as you withdraw. Changes the heart rate due to suctioning, so anytime we're managing someone's airway, we're also watching a heart rate. So when someone starts to get a hypoxic or not enough oxygen, and you guys will see this if you get going on calls, that first thing that happens is their heart rate goes up, and then they start to decelerate, or start to get bradycardia. Bradycardia means slow heart rate. The number one cause of slow heart rates is hypoxia. Hopefully we've corrected the problem before it gets to that point, but if we're ever really aggressive with suctioning, we've got a lot of airway to clear out, and we notice their heart rate starting to drop, we stop, ventilate them a little bit, get their oxygen levels up, then go back in and suction again. There is a maneuver that you may assist with, and it's called the salad maneuver. Was it suction assisted? Basically, if we gotta put a breathing tube in someone, we'll take this, we stick this in their esophagus and just leave it on while we're putting the breathing tube in. So that way if the person starts to vomit while we're in there doing this, this is getting 80–90% of it. Because otherwise, that airway, even though you're looking at the video, it looks real big, we're working in a space about like that. So that can fill up with fluid really, really quickly. Airway adjuncts. So we can use these in conjunction with head tilt, chin lift, stuff like this. And where did I put my nasal airway? Nasal airway. So a common where I would use these most commonly on usually three patients. Diabetics, where their blood sugar is dropped and they're not responding. We use them all the time on opiate overdoses. And with some stroke patients. So this is where they're not fully conscious. They're kind of in between conscious and unconscious, where they're still moving some air, but as an example, like we managed a lot of overdoses in Rapids, and I put a pulse oximeter on, and it was 80%. That's dangerously low. So we would put that in, and his oxygen saturation would immediately go up to like mid-90s, just by putting that in. No oxygen. All we did is we opened that pathway. So we'll learn about like hypoglycemia when a diabetic's blood sugar drops. It's we'll see a lot where they're snoring, they're not breathing, they might be breathing shallow, they're just not breathing effectively, and there's a handful of things we gotta do to fix that. That takes some time. Like we would want to start an IV, and we're probably going to give them a medication and an IV to get their blood sugar up. And this is from the time we walk in the door until we're giving them therapy, 5 minutes to 10 minutes. I mean, it takes time to get all this done. Well, in the meantime, we can address their airway by just really simply putting one of these in. And I'm doing the real fast version because Saturday we're going to have stations where you're all doing this, but I'll pass this around too. Nasal airways, most of them are beveled. So you'll see the tip is actually slanted. Kind of rule of thumb is we want that bevel towards their septum or towards the midline of the body when we put it in. So step one is we choose a size that's appropriate to the patient. This one is obviously too small, but it's because we're going into the nose, instead of measuring from the mouth, we measure from the nose to the tip of their ear. You can see here, I'm about that short. Suction devices, like the soft catheter, nasal airways, these are measured in French. And the bigger the number, the bigger the tube. So a 28 French nasal airway, which is the common adult size, is much bigger than a 20 French. A 14 French is bigger than a 10 French, so on and so forth. Now, when we talk like IVs, gauges are different. So the smaller the number, the bigger the gauge. So, but when we talk French, rule of thumb, like if I just have an adult, anyone in this room, minimum 28 French will probably take care of everybody. So to use a device, I take a little KY jelly, which is kind of our lubricant of choice in EMS. I lube up the tube. Take a pig nose out of them. So I'm going to go straight, I'm aiming straight back, and I just advance that in the airway, and you should not have to, if you feel like where it's holding up or you've got to push it, stop. If I meet resistance in the right nostril, and whether you go right or left, it doesn't matter. But if I meet resistance in one nostril, maybe they have some structural abnormality there, I can take the airway out, twist it, and advance it down, try to advance it down the other way. That's as simple as it is. So you put the airway in, you're good to go. You can put oxygen over the top of it, you can bag over the top of it. It's just a tool. And we use this for people who generally still have an intact gag reflex. Gag reflex meaning if I went and put my finger in your throat, everybody would probably not appreciate that very much. You're gonna either gag, bite, and this kind of essentially bypasses that reflex where I can put it in, I can put it in right now and you're gonna be fine. You might not like it. We do have some clean ones, and if anyone wants to actually practice on each other, we're happy to facilitate that.
You just put it in one nostril?
Hmm?
You just put one tube in one nostril?
Yep. You only need one. Now, if the person wakes up, and this is very common, that the nasal airway is kind of a temporary adjunct. So it's just buying us some time. Most of the time, the person is going to get better. They either get better, where we end up taking it out, or they get worse and we end up going a next level up. So it's kind of a temporary thing. If they wake up, like we wake up a diabetic with a low blood sugar and they get up and a lot more often than not, they just grab it. Or they're like, can you get this thing out of my nose? Absolutely. Just napkin, pull it out, they might have a runny nose. Worst case, it might create a little, if they've got really dry, you might get a bloody nose from it, but it's generally very, very minor. The next step is what we call the oral pharyngeal airway, also known as the OPA. They're all kind of similarly shaped like this. No, where did I put that? No, I just did it. Or did I pass it on? I was gonna pass it on. Someone's got to keep track of me here. This is the oral pharyngeal airway. We use this when we suspect they don't have a gag reflex. And if we go to put it in, if they do have a gag reflex, we'll know pretty soon. So it's more of a rigid device, and this serves the purpose of holding that tongue up off the base of the airway. Example, like cardiac arrest. Before we move to an advanced airway, this is something we can just put in really quick. These are also sized from the corner of the mouth to the tip of the ear. So you can see this is the appropriate size for this man. So corner of the mouth, tip of the ear. That's pretty much the right size. So this is the size I have. All different sizes for, down to pediatrics. So showing the measuring. Now it's kind of odd or counterintuitive when you think about it, but what we do is we're opening that airway with that scissor technique, and it's going to end up sitting like this in their mouth. Like this here, but we start putting it in like this, okay? And if we just took it and I put it in someone's mouth like this, what I'm going to do is I'm going to push that tongue back with it. So we go in initially the opposite way, where you open their mouth and we insert it, curve it until it hits that hard palate. And when it hits that hard palate, while we're putting gentle downward pressure, we twist it 360 degrees. And then it's in place. Now, you get to, if you're twisting it and they start to get a gag reflex, you just take it out. In fact, this is, sometimes we use it to test to see if they have a gag reflex. So, just kind of backwards, hits the hard palate, give it a 180 twist, and it just kind of slides right down into position. That's a safe one. If we're doing CPR, where I know they don't have a gag reflex, I have where I just grab their tongue, hold it, and slide it in. That is an option as well, but be sure that, see, it's getting hung up on the tongue line. This, we can't practice on each other. This would create a lot of hard feelings. So this one has channels on the side. Some of them are a little tube that are hollow in the center, but they're all pretty much the same shape.
So Jason, from the pictures that are in the textbook, like,
This way, this way.
That was a very good question, that, yeah, this is not, someone who's conscious won't let you do this. So, this is for people who have gag reflexes suppressed, that they have a, if they accept, and we'll see, you may hear the term, do they accept an oral airway? If the answer is yes, again, that is a temporary thing, we are going to be advancing to a more definitive airway. So it just buys time.
Is this the small, or like the biggest size that they have?
No.
Wow.
Yeah, there's probably 2 sizes bigger than that.
Container with all the sizes. Can I go get it? Hence the gap.
Sure. If you,
Yeah, that's fine.
so it sits there, and really it's not going past the epiglottis, it's just kind of holding that tongue up out of the way. So now, you know, technically if you're bagging them, you know, even if their head's not in perfect alignment, it just helps keep that air path open. Now with pediatrics, there is an old tongue depressor like I showed you, where it's, instead of putting your finger in, you're holding the tongue back with the tongue depressor, but the oral airway, we don't have to lubricate. So it's a nasal airway you have to lubricate. Now, I do want to, one device that you're going to learn is what we call a supraglottic airway. And there are a couple different proprietary versions. This is what's known as the iGel airway. This is what we predominantly use here in the Northwoods, and I think most systems are transitioning to this airway device. So the supraglottic airways, also known as non-visualized airways, meaning we don't have to go in with a laryngoscope and visualize airway structures. We just blindly insert these, open their mouth, put them in. The iGel is one. I think the 2 other more common proprietary brands you might see are the King LP airway or the Combi tube. And I'm going to have to try to find some of those airways, but the iGels are what we use. I like the iGels. Those other airways, there's like air balloons that we got to blow up. This one, there's no balloons. This is a gel tip, very flexible. That when this goes in the airway, it basically sits right over the top of your vocal cords. This tip actually goes down and occludes the esophagus. And you'll even see there's a hole that comes out through the tip there. And there's a hole up here. That flexible catheter is too big to go down this, but I can put a 12 French or smaller through there, where if this is placed, it essentially goes into the stomach. So I can start, you know, if we're starting to get emesis or stuff coming out around the tube, I can run a suction catheter and suction and leave this in place. Now, the insertion of these, we lubricate them very, very generously around the, especially around the, I don't know what you call it, the part that sits. And it might not, I don't know if it works for this mannequin, but same kind of maneuver of opening the airway that we do for, we don't have any lube, do we?
It's lube.
Yeah, what was there, some in the,
There's one in the bag here, y'all.
yeah. So just KY jelly, and I will just kind of get it. Now, lesson learned, what you don't want to do with airways is put the lubricant in your glove, lube it up that way, because now everything you try to touch or grab is going to slip around. So the end is lubricated. These are, you don't really need to size these, it's more based on height. So rough rule of thumb, if you're 5.5 feet or smaller, we use a size 3. If you're, I think, between 5'5" and like 6 foot, we use a size 4, and if you're over 6 feet, we use a size 5. And if you put one in and it seems too small, take it out, grab the next size up. If you put one in and it's too big, take it out, put the next size down. These are like 25 bucks a pop. Use them. So, but you just open that airway and it's literally, you just advance it until it stops. That's it. Now, this is a device that we use when the person is not conscious. If they have any kind of a gag reflex, they will fight you on it. These are set up and that once that's in place, and the kits usually have a strap that we can connect to these 2 barbs to run around the back of their head to kind of hold it down. But I can hook my bag up and I can ventilate the person with it. These are devices that you can carry in your kits. Literally take a couple seconds to put it. Super easy. And I know that now this is, I'm gonna pass it around. It's slobbered up. So, take a touch up here. But you can even flop it, you see it's flexible. Now, you gotta be careful with devices like that because when it's, like if you keep those in your kit in your car out now in the winter and you get a call, they're gonna be kind of rigid and stiff. So it's something we try to, you wanna keep room temperature, but. Yep, that's it. You just grab them like a bass and put it in. Yeah.
Orientation is actually, for some reason, it seems opposite from what I would think. The angle part goes toward the front of the gun?
Yeah, let me find that. We have another idea on there. So to put it in perspective, this is the big one, this is the number 5. And they even come in a kit with the, I've actually got a separate presentation just in the iGel that will probably start Saturday. Or when we're done with CPR, we'll just go through that. But like there's a certain way that if we're gonna put the strap on that we should run it around the person, but. So. You know, you can imagine if this person's down, but what I would do is I would open the mouth, here's the opening. So I'm gonna advance this in. So it's gonna sit like this, where that tip is in the esophagus, and then this has completely closed off so the air's got nowhere to go but that trachea. Does that make sense? So we don't have to twist, turn, you just go in with the curvature of the person.
David, Jason, I think, didn't you put it in with the diaphragm down on the video, and on this you put the diaphragm up?
No, well, you want the opening, so it's gonna be this way, forward stuff,
Okay,
because the
so
trachea, yeah, so when we go in, the opening's facing that way. And it was the same thing when I did, I know it's not, that's one thing, the iGels expire, so we have a bunch of them.
Yes.
We even have them for kiddos. So, here's the opening, right down here, that, yeah, we're going in like that, or on that mannequin, we're going in like that. So when if you're standing at their top of their head, you want that open facing towards everyone, so I'm going in.
Oh, okay, the heads are opposite, that's why I was using.
What time is it?
Time for a break.
Time for a break.
Okay, good.